Mr. Chairman, dear audience, I'll take you down from the Far East to the Middle East, where my city Basra is located. And personally, I feel knowing the pattern of disease all over the world is beneficial. And a good example this morning, when we heard about rheumatoid arthritis involving the cervical spine, I would say in our locality, it is very, very rare to see rheumatoid arthritis involving the cervical spine. So here we are. We have a total of 120 patients collected within 18 years, age range between 30 and 62, male 64 and female 56, single attack 45 patients, and recurrent attack in 75 patients. And here is the level of herniation, C2, C3, 5, and C3, 4, 10, C4, 5, 3, 30, and C5, 6, which is common all over the world, is 35, and then C6, C7 is, again, it goes with the international recognized level for. Site of herniation, lateral rotation 19, central in 65, posterolateral extrusion 20, and central sequestration in 18. Clinical presentation, neck pain was seen dominant, and it was in 87.5, radicular pain in 16, and paresthesia in 95.8. Limitation of movement was seen in 80%, abnormal hand position in 54, and neurological deficit in 17.5. Of course, spastic gait and loss of sphincter control and hyperreflexia is considered to be the cornerstone in the diagnosis. The severity of pain, agonizing pain was seen in 30%, and very severe in 34, severe in 25, mild in 3.3, and moderate in 5%. Severity of pain depends on the site and the size of herniation too. Associated degenerative changes were noticed in 46.7%. Is it job-related disease? The answer is yes. Bending neck for several hours when the artist or those working in banks, checking, stressful life condition, carrying heavy weight on the head. It's not usual here, but it is usual in our country for the laborers to carry heavy weight on their head. And of course, very high pillows, again, is a common and bad habit in our locality. Comorbidity, hypertension was seen in 20.8, and diabetes was seen in 31. And it's interesting that 9.2% had heart problem also. MRI was the best diagnostic tool, but still plain X-ray is mandatory, so we should not rush to MRI before plain X-ray. Serum and CSF oligoclonal band and immunoglobulin, we don't have it in our locality, but they said it's beneficial in the diagnosis. Differential diagnosis was tuberculosis, malignancy, thoracic outlet, and brachial neuralgia. Treatment, conservative treatment for 83 patient, it comes to 69.2, which is non-steroidal muscle relaxant, physiotherapy, steroid alone with continuous cervical traction. We found this is a good policy to give dexamethasone, short course, high dose, for 3 days, plus continuous cervical traction was useful in treating good number of patients. Operative, 37 patients had operative treatment. Discectomy, cage plate, we used to do it. It was done in 15 patients. Discectomy plus bone graft in 10. Simple discectomy in 12. Still there is a place for simple discectomy, and I don't feel fusion is routine for soft cervical disc. We use the anterior approach in 33 and posterolateral in 4. The outcome of treatment, pain-wise, very satisfactory. 85% had complete relief. Neurological deficit depends on the duration. At least it was stopped by surgery, if not abolished. All patients with neurological deficit were subjected to surgery. Surgery was done routine for them. And here we are, this is example of the cases which we operated on. It's clear. And this is the cage plate, which I feel it is very simple, very easy, very useful and very cheap. And also it's effective. It gives you fusion and stability. In addition, it's after removing the disc. And thank you very much.